Today, I will be discussing the efficacy of telemedicine depression treatment for those with Parkinson's. This study, titled Innovating Parkinson's Care, a randomized controlled trial of telemedicine depression treatment, was published in the peer-reviewed medical journal Movement Disorders in February of 2021. For decades, people with Parkinson's disease have had inadequate diagnoses and management of depression, resulting in the majority of Parkinson's patients who have depression untreated. With many Parkinson's patients being unable to travel the long distances for treatment, many have been left with poor access to neuropsychiatric care, which has left those with Parkinson's unable to achieve optimal outcomes. This study was conducted to compare the efficacy of clinic-based treatment as usual, the control group, to more individual Parkinson's-informed video-to-home cognitive behavioral therapy, the experimental group, as the video-to-home cognitive behavioral therapy, or VCBT for short, can help Parkinson's patients access treatment no matter their distance from the nearest clinic. This study was conducted using 90 U.S. military veterans who were diagnosed with both depression and Parkinson's disease, and they were then assigned to either the experimental group or control group using computer randomization. There was a 10-week acute treatment period followed by a 6-month extension phase. The results found that video-to-home cognitive behavioral therapy outperformed clinical-based treatment as usual. This shows that VCBT not only helps treat patients diagnosed with both Parkinson's and depression, but also means that this treatment can help bypass access barriers to specialized evidence-based depression care in Parkinson's disease, helping meet the needs of many in the Parkinson's community. So, what is Parkinson's disease? Parkinson's disease, or PD, is a progressive disorder of the nervous system affecting movement. This means that Parkinson's patients' symptoms worsen over time. PD is defined by the motor symptom triad of tremor, rigidity, and bradykinesia. But PD patients also face non-motor symptoms like dementia and REM behavior disorder. Up to 50% of people with PD experience depression, and depression in PD, DPD, is associated with faster physical and cognitive decline, poorer quality of life, greater caregiver distress, and increased healthcare use and costs. By reducing depression in PD patients with treatment, it can help improve PD outcomes. This is especially important in today's day and age with over 100,000 U.S. veterans with PD. The majority of individuals with DPD prefer behavioral treatments over antidepressants, which show why this study is so important. However, there have only been few PD behavioral interventions developed and tested. Other barriers include the shortage of clinicians with specialized PD knowledge and the distance to clinics. Telemedicine helps bypass these barriers. In this randomized controlled trial, 90 veterans with DPD, depression, and Parkinson's disease were placed in either the control group, treatment as usual, or experimental group, individual video-to-home CBT, through a computer randomization process. While the acute treatment period lasted for 10 weeks, the outcomes were monitored across a 9-month observation period. Male participants between the ages of 35 and 85 were recruited nationwide and had to meet the requirement of having a confirmed Parkinson's disease diagnosis and primary depressive disorder, as well as having a stable medication and mental health regimen, care partner availability, and internet access. Participants across 23 VA medical centers in the United States enrolled, and they lived, on average, 42.5 miles from their closest VA medical center. The average distance to their nearest VA Parkinson's disease specialty center was over 145 miles away. The primary outcome was change in participants' Hamilton Depression Rating Scale, or HAMD score. In general, with the HAMD, the higher the score, the more severe the depression. Participants in the experimental group, Video-to-Home Cognitive Behavioral Therapy, had a mean baseline HAMD score of 22.49, while participants in the control group, Treatment as Usual, had a mean baseline HAMD score of 21.60. Secondary outcomes, like depression severity, were measured using the 21-item Beck Depression Inventory, or BDI for short. The higher one's BDI score, the more severe the depression. The control group continued with treatment as usual, receiving routine clinic-based medical and psychiatric VA care. The experimental group received video-to-home CBT plus treatment as usual. And they received VCBT weekly for 10 one-hour sessions. Veterans received a session-specific link via email 24 hours before their appointment, and with one click was connected to the study therapist. Vets were also able to request a 10-chapter CBT for DPD workbook to supplement treatment. Video-to-Home Cognitive Behavioral Therapy outperformed treatment as usual for the duration of the trial. At the end of the acute treatment period, VCBT patients had a mean Hamilton Depression Rating Scale, or HAMD, score of 16.46, a score 6.03 lower than its baseline, whereas the treatment as usual control group had a mean HAMD score of 21.37 at the end of the acute treatment period, meaning their HAMD score was only 0.23 lower than their baseline. So what's this mean? The higher the Hamilton Depression Rating Scale score, the more severe the depression, and vice versa. So having a lower score at the end of the treatment period means the depression is less severe. And the lower a score is from its baseline, the score at the beginning of the trial, the better. Secondary outcomes also favored virtual-to-home cognitive behavioral therapy. With a mean baseline Beck Depression Inventory, or BDI, score of 21.09, the VCBT group's mean BDI score at the end of the acute treatment period was 11.19, a 9.9 score difference. With the treatment as usual control group, the mean baseline BDI score was 21.16 and was 18.91 at the end of the acute treatment period, only a 2.24 score difference. So what's this mean? The BDI measures depression severity, so the smaller the BDI score, the less severe the depression. During the duration of the trial, those receiving virtual-to-home CBT achieved significant and lasting reductions in depression compared to treatment as usual, and this was seen in both clinician-rated and self-report measurements of depression. Treatment feasibility, satisfaction, and adherence rates were high in this sample of veterans with both depression and Parkinson's. The findings of this study are particularly noteworthy because veterans with Parkinson's are more physically and psychiatrically complex than Parkinson's patients generally. In a global sample of Parkinson's patients, it was found that U.S. veterans reported more severe physical and neuropsychiatric symptoms like anxiety, insomnia, and dementia than non-veteran PD patients. And yet, veterans with PD have been chronically underserved by clinic-based neurology care. Telemedicine holds clear promise to address the urgent needs of improving access to informed, evidence-based treatment for individuals with both depression and Parkinson's. Individuals who received Parkinson's-informed virtual-to-home cognitive behavioral therapy achieved large, lasting improvements in depression, compared to those who received the usual care, whose symptoms remained largely unchanged. This sample was 100% male, which may limit the generalizability of findings to females. It's also not possible to fully separate effects of this VCBT intervention from nonspecific factors like therapeutic relationship, attention, that contribute to all psychotherapy outcomes. Overall, these results support future implementation efforts of specialized telemedicine interventions for depression and Parkinson's disease. Now, mental health providers with PD expertise could dramatically expand their reach, further improving global Parkinson's disease outcomes.